Hello and welcome to the educational program Embracing All Skin Tones, Advancing Research and Patient Management. My name is Chris Arrico and I am from Dooley Health and Care in Chicago, Illinois. I will be the moderator for this program. Today I am joined by Lauren Miller.
Thank you, Chris. Hi, I'm Lauren Miller. I am a PA practicing in Oxford, Alabama, and I have been in dermatology for 15 years.
Awesome. Nice to see you, Lauren.
Thank you.
And also today we're joined by Douglas DiRuggiero.
Good to be with you guys. I'm a PA that practices in Rome, Georgia. I've been in practice for the last 23 years. Honored to be here.
Awesome. Nice to see you, Douglas. So this presentation focuses on diversity and cultural awareness in our clinical practices. This is an important topic impacting both healthcare providers and patients, so we thank you for joining us today. Let's take a moment to review these important reminders. JANCE is committed to diversity, equity, and inclusion, or DE&I for short. They have several ongoing initiatives that have addressed the unique needs and perspective of patients and the healthcare community. This slide provides an overview of these initiatives. It might be helpful to level set on some terminology before we dive into our first topic. Race, ethnicity, and minority groups are terms which are often used interchangeably, but they're actually quite different. Data collected by the U.S. Census Bureau suggests that the term race is a social definition, without attempt to define it biologically, anthropologically, or genetically. An ethnicity is a group of people who share a common culture, language, religion, history, and other source of group identification without regard to race or ancestry. The term race and ethnicity are not suitable proxies for skin color. Using race as a surrogate for biologic or genetic inheritance is an unsuitable and controversial measure. A vast majority of humans share a common genetic pool. The stratification of skin color based on socially constructed racial or ethnic lines is limited and outdated. Now, let's discuss our first topic, diversity in clinical trials. Minority racial and ethnic groups remain underrepresented in U.S. clinical trials. In fact, over the past 20 years, the proportion of these groups has been small and disproportionate, comprising less than 20% of clinical trial populations. Additionally, clinical trials over-index on whites. Although white people comprise 72% of U.S. population, clinical trials enroll 80% white participants per trial. Lack of diversity occurs in dermatology clinical trials as well. 2 systematic reviews evaluated randomized controlled trials in specific dermatologic conditions between 2010 and 2015, and again in 2015 to 2020. The diversity metric was defined as at least 20% racial or ethnic minority participants. The reviews showed that the diversity in select dermatologic studies had not increased past this level over these time points. It's hard to believe that there hasn't been much progress made over the last decade or so in including diverse patients in clinical trials, and minority representation has been limited to industry-sponsored trials as well. The recent studies showed there have been less than 30% minority representation in industry-sponsored psoriasis biologic trials. The majority of Phase 3 psoriasis clinical trials, inclusive of topical, oral, and biologic therapies, prior to May 2020 enrolled about 86% of white participants, which is indicative of overrepresentation, as the estimated prevalence of psoriasis is 78% in non-Hispanic white patients. Let's also discuss another term we're hearing more about, skin of color. Skin of color, or SOC, is defined by the Skin of Color Society as people with pigmented skin that are of diverse racial and ethnic backgrounds, as well as individuals from these groups who have intermarried. As clinicians, skin of color is important as many clinical decisions are often made based on color and the appearance of that color is impacted by skin tone. Additionally, skin reactivity to injury is important when administering topical medications and performing common dermatologic procedures. Barriers start early in our educational career. Patients with darker skin tones are often underrepresented in medical textbooks. In the assigned textbooks at top medical schools, only 4.5% of the images were of patients with darker skin tones. A specific analysis of dermatology textbooks found that the percentage of images of darker skin was less than 20%. Additionally, a lack of exposure to diverse skin tones may also impact how healthcare providers practice. A study of dermatologists in the U.S. showed a positive correlation between the confidence in diagnosis and treatment in skin disorders in African American patients with the number of African American patients seen per week in both medical school and in residency. Psoriasis is more readily identified in patients with lighter skin because people with darker skin may present with less erythema. This can make it harder for healthcare providers to appreciate areas that are actively inflamed in patients with darker skin tones. People with a common self-identified background can exhibit a wide variation in Fitzpatrick skin type, which we'll talk more about shortly. Skin of color patients may experience disparate health care compared with non-skin of color patients. This includes waiting up to 3 times longer from initial presentation to final psoriasis diagnosis. This translates to a wait time of roughly 6 months for skin of color patients versus 2 months for non-skin of color patients. Additionally, skin of color patients are 4 times more likely to require a biopsy to confirm psoriasis diagnosis versus their non-skin of color counterparts. The difference in care that skin of color patients with psoriasis experience may be attributable to a lack of familiarity with diverse presentations of psoriasis among clinicians. Let's explore our second topic, evolving beyond Fitzpatrick skin type to objectively measure skin tone. Douglas, would you like to take us through this topic?
Sure, Chris. I'm happy to.
Before we start, can you give us some background on the Fitzpatrick skin type scale?
You know, Tom Fitzpatrick was a legendary dermatologist, and certainly the Fitzpatrick skin type, or what we call FST scale, was developed by him in 1975. And this characterizes different skin types of Caucasians, but really their response to UV exposure. So there are 4 types of skin types that were based on self-reported sensitivities to UV light and tanning activity. This scale was updated in 1986. You know, because we know it's got 6 components. So in 86, brown and dark-skinned individuals classified into categories 5 and 6 based on their pigmentation or their ethnic origin rather than on their responsiveness to sun exposure. And so this resulted in now what we know as our 6-point scale. Though not originally intended to serve this purpose, the Fitzpatrick scale really continues to be and is commonly used to describe someone's skin color. And so it's important to note that FST does not equal race or ethnicity. Although the FST has been used for many years, there is time and necessity for us to move kind of beyond that. People with skin of color have variable skin pigmentation, so terms used when self-identifying can be inaccurate and even culturally insensitive. So the FST scale also has limitations in its reliability based on, I think, these areas: subjectivity, skewed self-observer reporting, and recall bias. In fact, Tom Fitzpatrick himself openly acknowledged that race and ethnicity are terms with no scientific basis.
There are other more objective ways to measure skin color. Can you go through those?
Yes, I can. You know, since this is somewhat subjective, having like an objective measuring is very important for us, particularly as we move into clinical trials that want to incorporate more skin of color. So let's talk about colorimetry. So colorimetry, this is a device to objectively measure skin tone. Colorimetry has been around for 30 years. Measurement results are frequently reported using this International Commission on Illumination. And they use a lab color, and the LAB are separate terms, you know, the LAB color system in terms of the hue, the lightness, and the chromia of the skin itself. Colorimetry, it's used to measure skin tone, skin erythema, and the ability to tan. What's also interesting is that you can use colorimetry scores for lightness and color from a blue to a yellow hue and calculate, sounds scientific, an individual topography angle, ITA. ITA can objectively define skin tone on a spectrum from light to dark, and it's physiologically relevant measurement as it's been shown to correlate to both UV-induced DNA damage and biologically efficient dosing, or what's called a BED. So, not to complicate it further, but when we have something called a minimal erythema dose, your MED. The darker individual skin, the higher the BED will be. Another way to measure skin of color is the melanin index, or the MI for short. The amount of melanin is the primary factor in determining skin tone. So applying the absorption spectrum, again, I feel like I'm getting too scientific, of melanin to the spectral reflectance of the skin, right, allows for a determination of the melanin index. This is a parameter mainly influenced by the melanin content that someone has in their skin. Measuring melanin allows for kind of an empiric determination or calculation of skin tone. All skin tones have the same number of melanocytes, but those who have darker skin have more dendrites, more root-like substances, and they're slightly larger in size, and they're more active. They're producing more melanosomes, which then release melanin, and that increases the darkness of the skin. So what's interesting to note is that the ITA, that angle, and the melanin can be used together in skin type determinations, as they demonstrate a pretty strong negative correlation to one another. The higher the melanin index, or the melanin value, the darker the skin tone. The higher the ITA value, the lighter the skin tone. All right, so they kind of have this inverse relationship. Using melanin and ITA in combination with measuring changes in both erythema and melanin over time, I think can help determine a person's skin type more accurately than we've ever been able to do before. In addition, colorimeter scales can be used to differentiate between involved and uninvolved psoriatic skin. By using the simple equations for lesional and normal skin, the score can be determined. And so that's a long way of saying we've got very good tools at our disposal now to really remove the subjectivity of just someone self-identifying, this is what I think my skin tone is.
Yeah.
So
it's fascinating. What about cross-polarized photography? How can that help us with making a diagnosis easier?
when you use cross-polarized photography, this is a tool that helps us evaluate erythema. And you can see from these photographs on the slides that this type of photography enhances erythema visualization. So this cross-polarized photography helps us differentiate, in a nutshell, active psoriasis from post-inflammatory pigmentary alteration from psoriasis, and that's where it's very, very helpful.
Thank you so much, Douglas. That was very informative. Now let's move on to our final presentation in this program. Lauren, I'll turn it over to you.
Thanks, Chris. I'm going to be addressing the last topic of today's presentation, advancing cultural awareness. It's important to note that culture is complex and it encompasses a group's language, education, dialect, religion, cuisine, social habits, socioeconomic status, what they wear, belief systems, even music, arts, and much more. However, culture is neither race nor ethnicity. Many of us are striving to gain cultural competence for the diverse populations in our practice. Cultural awareness is important in all of our patient interactions, and it helps to enhance patient-centric care, and it helps to really reduce that healthcare disparity. Unfortunately, when culture is dismissed, potential health disparities and suboptimal health outcomes could result. The biggest hurdle for employing cultural awareness is the assumptions that we make when we first meet a patient. It's important to be aware of our own internal biases and prejudices and keep them in check. Here, we see the differences between cultural awareness, competence, and knowledge. It's important to have a good working knowledge of these concepts as they relate to diverse patient populations that we often see in our practice.
Lauren, totally agree. Incorporating cultural awareness into our practice is an important aspect of patient communication. What tips might you have?
I have several. So first, let's take a moment to review some of the best practices for cultural awareness. So first, we want to accept and respect the differences of our patients. We want to pay attention to social cues and room dynamics. We want to avoid ethnocentricity and preconceptions. We also want to proactively ask about culture to avoid any misunderstandings. Respectfully communicate with the patient as an individual and take the time to really learn about the cultural norms that are important to each patient.
That's great practical information, Lauren. Thanks for sharing these tips. Also, as this program draws to a close, I just want to point out that there have been many recent innovations in clinical trials to address disparities and challenges related to diverse skin tones. These include objective measures, inclusion of all self-identified as non-white patients, tools to objectively measure erythema and melanin, and patient-reported outcomes to address questions important to the community. On behalf of all the faculty, I would like to thank you for your interest in this program. If you have any additional questions about this content, please follow up with your Janssen representative.